All right. Sorry about that. I'm on orders for the rest of this month and into next, like the first half of November. So I'm going to be teaching from the military base. It's making life a little bit more hectic on class days, which is why I was late. I apologize. Actually, today ran pretty long. But anyway, we're going to get started. Tonight we're doing neurologic emergencies. So what's the first thing that comes to mind before we even get off the title screen? If somebody's having a neurologic emergency from a medical standpoint, what's the first big thing?
Stroke.
Stroke, exactly that.
CVA.
Yep, could be problems with the brain, could be head injuries if it's trauma related. Stroke, seizures, any of those, there you go. Good job. That's going to be the big things that we talk about. All right, so stroke is actually the fifth leading cause of death and the leading cause of adult disability in the United States. Not everybody dies from a stroke. Not all strokes are the same. It just depends on what's hurt, where in the brain the problem is. This is very common in geriatric patients. Some contributing factors that we're going to see include family history and race. So African Americans, you guys kind of get the short end of the stick here. You're more at risk of getting sickle cell anemia, you're more at risk of stroke, and really and truly, I think and correct me if I'm wrong, but if I'm not mistaken, the sickle cell is one of the reasons why you're more susceptible to it. Hispanics and Asians also have a higher risk for this. Treatments are available. As you can see there, the only thing about it is, and I want to foot stomp this all night long. Time is a factor. All right. So when you're dealing with a stroke patient, it's one of the best questions or biggest questions you're going to want to ask is how long have they been having a problem? So the way that I usually word that is, when were they last normal? It's the easiest way to put it, because like I said, I mean, some people will have weakness on one side of the face. Some people will have a hard time talking or understanding words. It really just depends on where the problem is at. So rapid transport, that's why I said it's right there. Rapid transport is vital. The longer you take, the less likely the meds are to work, or not the meds, the procedures. So seizures and altered mental status may also occur when there's a disorder in the brain. So that's pretty much the other half of tonight's lecture is going to be on seizures. We're basically talking about brain injuries from a medical standpoint. So seizures may occur as a result of a recent or prior head injury. Football players, anybody that's been in a car accident, hit their head really hard, they're at risk for this. A brain tumor can do it. Metabolic problem, fever. What's it called if somebody has a seizure from a fever? Anybody know what that term is?
Febrile.
Febrile. There you go. And then a genetic disposition. So some people are just, it's in their family. They might get it. The febrile seizures usually only happen to kids. Or at least, I'm sorry, let me rephrase that. It's not that they only happen to kids. They are more common in kids. If an adult gets bad enough, they'll have a seizure as well. But you really we normally see it in kids because, like, when they're teething, they'll get these really high fevers, and sometimes it'll cause a seizure. That's not a long-term issue for them. It's just because of that fever. Some possible causes for altered mental status: we have intoxication. Won't go into that too much tonight. Head injury, hypoxia, stroke, and metabolic disturbances. And depending on what it is, the treatment can be one of a ton of different things. So let's do a quick review of the anatomy. What is your central nervous system primarily composed of? It's two major things. Brain, spinal cord, exactly. All right, so that's your central nervous system, and then we have our peripheral nervous system. That is basically everything else. All right, so we're going to focus on the brain, but be aware, especially when we start talking about things such as when we get into trauma, and we're looking at sensory perception and motor function and stuff like that. We're actually starting to work more with the rest of the nervous system. But tonight we're really going to focus on the brain. There are three major parts of the brain. We have the brain stem, which is where the cord connects to the brain. It's at the bottom. The cerebellum and the cerebrum. The cerebrum is the largest part. The brain stem controls most of your basic functions, including your actual consciousness. So here's the thing: if we have our brain that's enclosed in our skull, right? And then the spinal cord runs down our spine. There's got to be a way, because that's one connected piece. There's got to be a way to get that cord to come, or to get the brainstem and the cord to come out of the cranium and to run down your spine. So there's a hole there. However, that hole usually, because of the amount of pressure, is built to withstand the pressure that's inside the skull, and it doesn't really like let the brain fall out or push out or anything like that. There are going to be times, and we'll talk more about this when we get to trauma, but there may be times where the problem is that they've got swelling in the brain, or they've got something causing increased cranial pressure that is eventually going to push everything in there the only way it can go, which is through that hole. And the problem with that is that your brainstem and all your life functions are right there. So if you shove this thing, the brainstem, out of the skull and into the spinal column, and it does damage to it, that's where your life threats are going to come from. The brainstem controls a lot of your vitals. So breathing, blood pressure, swallowing, pupil constriction, all that stuff comes from the brainstem. And that is why whenever we see head injuries, a lot of times we'll see their vital signs start to really get way out of whack. Cerebellum, which is down there, it's kind of behind the brainstem. This controls all your muscle function. So your body coordination, your walking, riding, hand-eye coordination, all that stuff is taken care of in the cerebellum. The cerebrum, which is the big chunk of your brain at the top, that's what most people think about, is divided into the right and left hemispheres. We have a couple of lobes. I'm not going to really make you guys get into that too much. Let's see, already past that slide. We're not going to get into too much of the lobes. That's more of an anatomy physiology class, but I want you to know what that area mainly does. So you've got your memories, your senses are processed there. So like the temporal lobes on the sides process your smell and hearing. The occipital lobe in the back processes your sight. That's the kind of thing that I want you guys to know. You don't have to know their names or anything like that, but just know that that's where your senses and how you perceive the world, that section of the brain does that. Our memories are stored in the front of it. So all right. In most people, speech is controlled on the left side of the brain near the middle of the cerebrum, and that is both lanes of the road. That's your ability to speak as well as your ability to understand what's being spoken to you. There's two little sections on the left front side of the brain that handle that. So if there's ever a problem that's affecting that side of the brain, that's usually what's going to be one of the big symptoms that you see. If they're having problems on the other side or in the back or something like that, their speech may not be messed up, but sometimes it is. It just depends on what you're dealing with. And those are the hard patients because they can't tell you what's wrong. They'll use the wrong words. They think they're talking normal because to them they are, but it's not always the case. They may be trying to say like, I want a glass of water, but they say I'm going to the bathroom, or something like that just comes out. Messages sent to and from the brain travel through nerves. All right, so 12 cranial nerves run directly from the brain to parts of the head, and they control your eyes, ears, nose, and face. Is how we make our expressions. The rest of the nerves join on the spinal cord, and they run kind of like just straight down all the way to the base of the spinal column. Each one, or every so often distance, there's gonna be nerves that branch out from that go out to the different parts of your body. So you can kind of look, and that's where you run into the issue of like if somebody has a break in their spinal cord, wherever the break is, everything below it stops working because it's got to get that message from the brain down to them. But the cord's not. You'll learn more about this as paramedics, or if you go to that extent. But your cord has different functions. Think of it like a tree trunk with bark. So you have your inside, right? You have your inner cord, and then the bark, that outer layer, it also has a function. It's not just one solid piece. The cord has an anterior and a posterior side for that outer sheath, and each one of those does a different thing. We're three-dimensional people, so the cord has 360 degrees of function, and depending on where you've either pinched the cord or completely severed the cord, you'll actually see some symptoms, whereas you may not see those same symptoms in somebody else. At each vertebra in the neck and the back, two nerves branch out. These are called your spinal nerves, and they carry signals to and from the body. So if I were to take my hand like an idiot and just plant it on the hot stove or in a fire, those are the nerves that are going to tell me to move my hand. All right, so here's just a picture of the anatomy of the neurologic system. So you have your brain. The brain stem is at the bottom, and like I said, that's where your consciousness is. So we actually have been able to find that there's a spot called the reticular activating system, or RAS. That's where your consciousness is at. So I'm not saying your soul, but just your ability to be awake. If something hits you and knocks that nerve out or deadens that nerve, you're going to be out like a light until it comes back. So people get into comas. A lot of times it's because something happened to their RAS, which is in the brainstem. Many different disorders can cause the brain dysfunction and may affect the patient's level of consciousness. Usually that's the first thing to go. Speech and voluntary muscle control. The brain is most sensitive to changes in oxygen, glucose, and temperature levels. Think about it like I said earlier in the class. The brain is the biggest baby in the body. The minute something is not quite right, it's the first to speak up. So that's where that altered level of consciousness comes in, that higher anxiety, all that stuff. A significant change in any of those things can be pretty drastic, especially when they drop. Hypoglycemia, you may have a friend that's like the nicest person on the planet, but when their sugar drops and they start to lose that level of consciousness, they can get combative. It's like a Snickers commercial. You're not you when something goes wrong there. If a problem is caused primarily by disorders in the heart and the lungs, the entire brain will be affected. If the problem is in the brain, then only that part will be affected. So let's talk about headaches. I had one of those pretty massive earlier today. One of the most common complaints you're going to hear from patients in terms of pain is a headache, and that's with most of your neurologic issues. Headache can be a symptom of another condition. Usually your head doesn't hurt just for the hell of it, right? It's not, you're not going to just, oh, I got a headache for absolutely no reason. Sometimes that reason might be your fault. Sometimes it's not. Only a small percentage of headaches are caused by a serious medical condition. So just because they have it doesn't mean that there's anything necessarily life-threatening, obviously. But there's usually a cause, and you can kind of pursue that too. So you can say like, well, where does it hurt? Well, it hurts around the temples, okay? Or maybe it hurts like front and center in the forehead. Let me ask you this: if somebody's got a headache and it's just right in the forehead, what's an easy way without using meds? Let's say that you don't have access to any medications. What's an easy way to make that pain either go away or subside a little bit? Here's a trick. I don't know if anybody knows this. Okay, so not a sinus headache. Think muscle. Actually, it would be, as far as temperature goes, you'd want to use the opposite, heat. Corn in the microwave. I haven't heard that one. That one you'll have to. So, I don't know what you're talking about. You're gonna have to explain that one. So, wow, there's a lot of tricks. Okay. Well, the big one that I was going to talk about is if it's a tension headache. If you rub or like massage the base of the head in the back above your neck, um, a lot of times that's a connection point for the muscles that run along the top of your scalp that we really don't have a lot of control to move, but they're there regardless. When we get stressed, when we get a lot of tension, that you tense your neck up, or you're not sitting right or whatever. Um, if you massage that area, that causes the muscle to relax, which actually will lessen the headache that you're feeling. So that's something that you can try if you're trying to figure out what kind of a headache do I have, because that might change the medication you take. If you're going to take an NSAID or say like acetaminophen or something like that, um, try massaging at the base of the skull and see if it makes the pain go away, or at least get better. So tension headaches, migraines, and sinus headaches are the most common. They're not life-threatening. Um, Tension headaches, like I was just saying, are usually caused by muscle contractions in the head and neck, you, by stress. Um, the pain is usually described as squeezing, dull, or as an ache, and there's really not a reason to call 911. People will do it, but there's nothing you can do, or that you would need to do, because there's no life threat. A lot of times, you just take some Tylenol, um, and you're fine. Or like I said, rub the base of the neck. So, oh yeah, migraines are horrible. I've heard for migraine, you can submerge both hands in cold water and it relaxes the nerves. I haven't heard that. Um, you know what? I'm gonna remember that, and I'm gonna try it next time I have a migraine, and we'll see. Don't know if it works. Well, like I said, I don't mind being a guinea pig for that. Um, for migraines, we really don't know a lot of what causes migraines. Unfortunately, we have like our best guesses, but we don't. We're still learning. They're thought to be caused by changes in blood vessel size at the base of the brain, which does a couple of things. It drops your blood pressure, which can cause headaches. Just like how when you give somebody nitro, remember I told y'all one of their common side effects is going to be a headache because we lowered their blood pressure. Same thing here. Also, if you dilate the blood vessels in the brain, or in the skull, what do you think that does to your intracranial pressure as a whole? Not your blood pressure, but just the pressure in the brain or in the skull. Yes, it will increase the intracranial pressure because you put bigger objects up there. If you dilate the blood vessels, more blood is going to get up there. So that sometimes can cause a migraine. I think it makes more sense to say blood vessels, not, did I say nerves? Oh, for yours. I was about to say, I've been off my rocker all day. I could be, okay. I was about to say, I may be throwing the wrong words out there. Um, for migraines, anybody can get it, adults and children. Women are 3 times as likely as men to experience migraines. I'm not going to argue that point. Almost every female I know, every woman I know has got migraines, and I think I've only had like 1 or 2 in my life. Pain is usually described as a pounding, throbbing, or pulsating, which makes sense, especially when we're talking about those blood vessels expanding, right? Because you're going to basically feel your pulse in your head. Um, Migraines are often associated with nausea and vomiting and may be preceded by visual warning signs such as flashing lights or a partial vision loss. Um, it's almost like how some patients will see an aura before they go into a seizure. You can kind of tell that it's coming on, especially if you get them often. You'll start learning some little signs that are like, oh crap, I got a migraine coming. Um, Migraine headaches can last for several hours or days. So, and those things are no joke. Sinus headaches are next. Sinus headaches are caused by pressure that is the result of fluid accumulation in the sinus cavities. So if you've got a blocked sinus, then fluid starts to get in there. So typically we run into this in, say, like the spring if we have allergies, something that kind of clogs up our sinuses. That fluid gets in there, and fluid in general is not a problem. The problem is when it starts to put pressure on things. Um, why do we even have sinuses? Anybody know some practical applications of like physiologic? Why do we have sinuses? Well, yeah, okay, so yeah, some sinuses we do breathe through. There's a couple of reasons. There's a bunch. One of the biggest reasons that always stands out to me and it makes perfect sense is weight. Nobody really thinks about the fact that your bones are heavy, right? Um, there's a balance to it. Sinuses are usually empty pockets within your bone, so it takes away some of the weight. But yeah, we do use them for other things, like you are saying right there. So it's a good filter as long as they're functioning right. If you actually do get sick and they clog up, then they can't do what they're supposed to do, and they can make it very hard for you to breathe. Serious conditions that include a headache as a symptom or hemorrhagic stroke, which is where you bleed into the brain, a brain tumor, and meningitis. Have we talked about meningitis in this class? Okay. So think about the name, right? We'll probably get into it. If we haven't already, we will. But for now, just think of the name. What does meningitis say to you when you break the name apart? Okay. Inflammation for sure, not necessarily the brain itself. It's inflammation of the meninges. So the problem with that again, and one of the things that we talk about with meningitis, one of your biggest signs that you've got it is, or not a sign, I'm sorry, a symptom, um, is a stiffness in the neck. It hurts to turn your head. So the reason for that is because, like I said, you only got so much room up there. All the space is taken. There's no empty space in your head. There's a pressure that is maintained, and yeah, well, there's sometimes it can be viral as well as infection, biological. But when meningitis starts to get really bad, you start swelling down around the brainstem. It becomes harder to move your neck because that swelling is taking up more space, and it's gonna hurt, hurt, hurt. So like you'll feel it. You know, nobody's like, oh, turns out I have meningitis. Didn't even know it was there. You'll know something's wrong if you ever get it. So you should be concerned if the patient complains of a sudden onset severe headache or a sudden onset headache that has associated symptoms. When you're talking about hemorrhagic strokes here, you should suspect a stroke in patients with a severe headache, seizures, and an altered mental status, just in general. All right. Signs of increased intracranial pressure, which is ICP, include headache, vomiting, altered mental status, and seizures. And if you notice, it says vomiting, but it does not say nausea. All right. Yeah, I've mentioned a couple of times that that's a pertinent negative. So if somebody is just, hurling and they have no buildup, no warning, no nausea that's letting them know that they're about to throw up, that screams head injury. If there is nausea, a lot of times that is due to a GI problem. But if that's missing, that should point you to the head. So one of the biggest things that we want to do, kind of treat your patient like a heart patient. The more we up their pulse, a lot of times their blood pressure is going to climb with it. And if they have intracranial pressure problems, it's going to make the matter worse. So you can kind of consider not using your lights and sirens during transport, but that's going to be up to your agency. For stroke, um, that's our blanket term. It's a cerebrovascular accident, CVA. basically what's happening when we have a stroke is that for whatever reason, the brain is not getting perfusion from the bloodstream, and it can either be a blockage, it could be because you're losing blood, right? So a hemorrhagic stroke, um, anything. So it's like saying a stroke is kind of like saying you're in shock. It's it's a broad term. Lacking oxygen, brain cells stop functioning and begin to die within minutes. Sounds a lot like a heart attack. It's just for your brain. Once brain cells die, not much can be done. So again, timing is everything. Brain cells develop ischemia, the reduction in blood supply that results in inadequate oxygen being supplied to the cells, causing the cells to stop functioning properly. So if it's the section of the brain that controls your speech, your ability to make your words and everything, and have a language, um, if those cells get affected, then you're not going to be able to do that. So some patients will have a stroke that affects their memories. Some will have a stroke that affects their motor function. And again, if the stroke is not reversed in time and that damage really does start to take hold, they're not going to really recover from that. It's once the cells are dead, they're dead. So we really want to try to hurry up and get them to help from there. It may take several hours or more for cell death to occur, so you do have a little bit of time, because little trickles of blood may be keeping ischemic cells alive, especially if there's a blockage. It may not be a complete block. It may just be enough that they can't function properly, so they're going to get some signs. With prompt restoration of blood flow, the cells won't die and the function can be preserved or even restored. My grandfather had a stroke a few years back. Luckily, it didn't happen in the middle of the night or anything like that, so everybody was awake. We got him to the hospital pretty quick, and he's fine. He hadn't had any problems with it since. But it was a scare. Like we were a little concerned. Well, we were very concerned that it was going to be something that he either couldn't come back from or was going to have some kind of disability or whatever. But he made a good recovery. There's a couple of different types of stroke. We have ischemic, which is just a lack of oxygen, right? The blood is not there, so that's usually caused from a blockage. And hemorrhagic, which is the actual loss of blood. Remember, your blood should stay in the vessels. If for whatever reason, say like you have a hypertensive emergency, which is where your blood pressure skyrockets really fast, your vessels can't keep up with it. They might burst. So in an ischemic stroke, this is where the cerebral arteries are blocked. Hemorrhagic is when you've lost blood, and then when you have that problem, you also have the problem of increased intracranial pressure. So if it's a hemorrhagic stroke, you see a lot more widespread symptoms. If it's a blockage, it depends on where the blockage is at, how far up the blood vessel path it is. But if it's all the way down to like one of the last little branches, they're going to have a very specific issue go wrong, and sometimes people don't even notice it. It just depends on what it is. So ischemic strokes, these are the most common according to the American Stroke Association, which is about 80% of the strokes that we see out in the field. Again, this is basically caused by a blood clot or an embolus. An embolus, actually, you know what? Y'all tell me, what's an embolus? Thrombosis is a clot. So what would be an embolus? Let me ask you this: have y'all ever heard of the term embolism? Well, that's thrombosis. So the thrombus is the clot. So it's a solid blockage if it's a thrombosis. If it's an embolus, that is air that has gotten into your system. That can be fatal. It's just as bad. Yeah, as an air bubble. It's just as bad as, say, an actual clot, because what it's going to do is it breaks the ability of the blood pressure to continue pushing the blood through. So the blood that's past that embolism just kind of stagnates. It sits there. There's nothing that the blood behind it can't do anything with it. So it may as well be a solid block. Um, let's see. Symptoms may range from nothing at all to complete paralysis. So making sure I was on the right slide. Atherosclerosis in the blood vessels is often the cause of an ischemic stroke. So again, as we go through our life, be it for poor diet or just bad luck on the genetics drawing, when our blood vessels start to harden up and we start building that plaque on the inside, if that breaks loose, that can cause a stroke. Usually that's the problem. So a lot of times they already have, some signs that they may be having this issue. Other issues could be atrial fibrillation, but we'll get to that. So atherosclerosis, we've talked about it before. This is where you get those calcium buildups inside of your arteries. If they completely, it may not even be a clot like floating around like a thrombus. It might actually just be that that blood vessel got completely clogged up with plaque right there at the spot. It just depends. But this plaque may obstruct blood flow, and depending on how big that piece is, determines where it's going to get stuck at. Like, so the one in the picture here, that's a pretty big blockage. It blocked a lot of blood vessels below it, but sometimes they may be small. And like I said, you can kind of get them in those end of the road type areas. Even if a blockage in the carotid artery is not complete, so if it's, which is what that is, most of the time your blocks are going to be way up in the brain, even though it is still the carotid artery. It's not necessarily at the point of where we're checking our pulses. It wouldn't be anything that big. But even if the blockage is not complete, small pieces of the clot may embolize deep into the brain and become lodged in a smaller blood vessel, blocking the flow. So depending on the size, it could cause some really serious problems. The blood vessels in the brain are very small, and they need to be. There's a lot of them. They're just not big. All right, hemorrhagic stroke accounts for 13% of strokes, according to the American Stroke Association. This results from bleeding inside the brain. A lot of times these can be trauma related. Like I said, though, hypertension can do it. So you got to be careful. Your patients are having a hyperglycemic attack, their blood pressure is skyrocketing with it. They're at risk of a stroke. So this results from bleeding inside the brain, and it's going to up the pressure. So you're going to see a lot of other issues as well. Blood forms a clot, which compresses the brain tissue next to it. And one of the coolest things, well, I say cool, it's not a good thing. It's just something that you can kind of look at. If you track your patient's eyes, they will point to where the brain injury is at. So if there's a hemorrhagic stroke, let's say you've got blood pooling up in one certain part of the brain and it's pushing, it kind of pushes its way toward the center, it hits the optic nerve. Whenever the nerve gets pressure on a certain part of it, it actually forces the eyes to pull toward it. So if your patient is looking up and to the left, then that's probably where the actual injury is in his brain. And if that's the case, it makes sense that he may or may not be able to understand you or talk to you very well or any of those kind of things because of what's on the left side of the brain. All right, let's see. Okay, there we go. Yep. A lot of times, unfortunately, these are the ones that people don't come back from. It's very hard to fix a hemorrhagic stroke. So a lot of times these are fatal. People at high risk include those experiencing stress or exertion. And people at the highest risk are those who have a very high blood pressure, like I said, or long-term elevated blood pressure that's not being treated. Even if it is being treated, if they're not taking their medicine like they should, this is one of the downsides. This is one of these risks. All right, so an aneurysm is a swelling or an enlargement of the wall of an artery resulting from a defect or a weakening of the arterial wall. We talked about this in cardiology. This can happen anywhere. Granted, smaller blood vessels, you're not going to die from the blood loss like you would if it was in your aorta, but it can still cause a lot of issues, and especially if they rupture, they can lead to the hemorrhagic stroke. So if you have a patient that has an aneurysm, a brain aneurysm, one of the symptoms is in sudden onset of a severe headache. So they might be just sitting in the chair watching Jeopardy, and suddenly they get this like excruciatingly painful 10 out of 10 headache that um, hurts in like one part of the head. When a hemorrhagic stroke occurs in an otherwise healthy person, it is likely caused by a weakness in the blood vessel, which is called a berry aneurysm. So berry like blueberry. Surgical repair may be possible if care is sought immediately. Hopefully your patient is awake and they know something's wrong so they can go to the hospital. Otherwise, they wind up, being like the next morning they find it. And a lot of times those don't work out very well. All right. Transient ischemic attacks, or TIA. These are basically temporary strokes. So a hemorrhagic stroke will never be the cause of a transient ischemic attack. Usually it's going to wind up being a blockage that winds up fixing itself. So let's say you've got a clot, right? And it blocks blood flow. The brain starts to suffer. They show signs of a stroke. But with each beat of the heart, it moves that clot just a little bit more until it finally breaks loose and continues on, and now your blood flow is back. So your symptoms go away. When blood flow to the brain is obstructed due to atherosclerosis or a small clot, the patient may have the signs of a stroke, but if the clot moves for whatever reason, then the signs they're going to go away. No actual death of tissue occurs with a TIA because these things are temporary. If it's a full-on stroke and it's not a TIA where it's not going to fix itself, usually those are the ones where you get the tissue death. A TIA can last up to 24 hours. So that being said, if they called you because something happened like 2 hours ago, there's no way that you're going to know the difference between a TIA and a full-on stroke. We don't diagnose that in the field. So as far as like getting it down into practice, bottom line is if it looks like a stroke, treat it like a stroke. Even if it is temporary, get them to the hospital as quick as you can. If they wind up clearing up, then fantastic. But you don't want to be the one that sits on scene trying to determine if it's a TIA when your patient's really having a full-blown stroke. All right. Although most patients with TIAs do well, it is still an emergency. About 1/3 of every patient who has a TIA will experience a stroke soon after. Because again, right, that clot didn't just disappear. It just got knocked loose. It's still floating around up there. It's going to wind up getting stuck again. So they need to go to the hospital. They need to get checked out, see if the doctors can find the clot and remove it before it becomes another issue. This is everything we were just talking about. All right, some signs and symptoms of a stroke. General signs and symptoms include the following. So you're going to have facial drooping, sudden weakness or numbness in the face, arm, leg, one side of the body, all that stuff that everybody pretty much knows. Decreased or absent movement and sensation on one side of the body. Lack of muscle coordination, which is ataxia is the term for that, or loss of balance. Sudden vision loss in one eye or blurred and double vision. Difficulty swallowing, decreased level of responsiveness, speech disorders, aphasia with an S, not a G. Difficulty expressing thoughts or inability to use the right words, or difficulty understanding spoken words. So again, that left front area of your brain where your ability to speak and understand being spoken to, if that's where the problem is at, then you're going to see those signs. Not everybody is going to have every symptom. It just depends on what area is affected. Usually the muscle weakness is going to be your common, like everybody's going to have it just because your muscle coordination is almost universal. So if it's back there anywhere in the back on the posterior side of the brain, a lot of times you're going to see that. But you still have the sudden and severe headache, confusion, dizziness, combativeness. If they have a altered level of consciousness, they can get combative, restlessness, tongue deviation, and coma. All right, so let's talk about this real quick. You have your left hemisphere of your brain and your right hemisphere of your brain. Which one controls the left side of your body?
Right.
The right hemisphere controls the left side of the body. All right. What about the left side of your face? It's actually the other way around. So we've all been taught, I remember learning this in school. Oh, the one side of the brain controls the other side of the body, which is true. Like say the left hemisphere controls the right side of the body. However, that split or that twist doesn't happen um, at the face. The face is still controlled by the right side of the brain. So, or I'm sorry, controlled by its own side of the brain. So the left side of the face is controlled by the left side of the brain. The right side of the face is controlled by the right side of the brain. So when you're looking at a patient, one one way to kind of figure out if they are really having a stroke is, does the body's weakness and the facial droopage, is it all on the same side of the body? Or is it, it'll be like the right side of the face, but the left side of the body? Yeah, well, you're gonna ask them to smile, but you need to say smile, grimace, anything that makes them have to use both sides of their face. But my point being though is that if the right hemisphere of the brain, for example, is the one that's being affected, it'll be the left side of the body, but it will also be the right side of the face. So you can kind of look at it like the twist happens in the neck. It doesn't really happen in the neck, but that was how I learned to understand it. So for your left hemisphere, um, if you have a stroke in this area, you can have the aphasia because you're going to have that part of the brain that's affecting your speech. Strokes that affect the left side of the brain can also cause paralysis of the right side of the body, but again, it'll be the left side of the face. For your right hemisphere, if you have a stroke on this side, um, right side of the brain can cause paralysis of the left side of the body. Usually patients will understand language and be able to speak, but their words may be slurred and hard to understand because they're going to have like a altered level of consciousness. Patients may be oblivious to their problem. This symptom is called neglect. Patients with the problem affecting the back part of the cerebrum may neglect certain parts of their vision. Um, and then neglect and lack of pain cause many patients to delay seeking help. A lot of times they just don't know that anything's wrong with them, especially when you don't have any pain. That's usually our telltale sign that something's wrong, is that we hurt, but not everything has a nerve ending that registers pain. All right, bleeding in the brain. Patients may have very high blood pressure, which could be the cause of the bleeding, or it can be caused by the bleeding as like a compensatory response. So if we're bleeding out, um, our body is going to try to maintain blood pressure by cranking down on the vessels, raising our heart rate, and that kind of thing. Is going to try to maintain your blood pressure. A trend of increasing blood pressure is an important sign. So if you check somebody out and they're at 150, and then you check them again 5 minutes later and they're at 200 systolic, that's a major problem. Significant drops in blood pressure may occur as the patient's condition worsens, because again, we're looking at it like from a shock standpoint. They're going to try to maintain for as long as they can, and then they're going to start to crash when the body wears out. Monitoring the blood pressure for changes in these patients is very important. So if you're a little concerned about it, there's nothing saying you can't get a blood pressure more often than 5 minutes. We do the 5 and 15 for stable and unstable, but that's a minimum. So you will at minimum get it every 5 minutes. But if it's something like a stroke, or where you're really wanting to watch it and catch this trend early, you can check it every 2 minutes, every 2.5 minutes, or whatever. In fact, a lot of monitors have the ability to set a schedule for how often they're going to do the blood pressure. You as an EMT, if you have just your regular standard manual cuff and everything, you can't obviously program that, but you can always set a little timer on your phone that says every 2.5 minutes or whatever, I'm going to recheck his vital signs. Some conditions that can mimic a stroke: we have hypoglycemia, which is low blood sugar, and also the postictal state, which we're going to get into seizures here in a second. But This is the period that follows a seizure. Usually lasts about 5 to 30 minutes. Um, it's the patient's laying there on the ground. A lot of times, if somebody has a general seizure, they're not going to just bounce up and go back about their day like nothing happened. There's always, it's like they're gonna lay there for an unknown amount of time while their body just basically recovers. So they may have labored respirations and some degree of alternate mental status. Like I was saying, I think I told you all about the guy at the base gate down in New Orleans, the ones that had a seizure. And yeah, I remember talking about it now because we were talking about refusals. When we got there, he was up walking around talking to people and he seemed fine. But after, we were checking his LOC and his orientation, and we found out that even though he was up talking to us, he really wasn't in his right mind. So other things, subdural and epidural bleeding. This is a collection of blood near the skull that presses on the brain. So you have your arteries and your veins that run to your brain that kind of go along the outside. Um, Depending on where the bleed is, it can have a fast onset if it's arterial. It can have a slow onset if it's venous. It just depends. So they may not be having a stroke, but that pressure buildup can be causing some other issues. All right, so yeah, you can see it here on the right. Um, that blood pool is going to be pushing down on the brain, and depending on where the problem is at, it'll be pushing, and you're going to see the symptoms based on where the brain is being pushed. All right, take 10 minutes. We'll move into seizures and keep on trucking. All right, let's get back to it. It's getting kind of cold in here. All right, so seizures. We're going to move on to seizures now. A seizure is a neurologic episode caused by a surge of electrical activity in the brain. That's pretty much the basic definition of it, right? It can be for any number of reasons, as we talked about. But it's basically where the brain just kind of spazzes out, sends out electrical activity in all different ways, and that may or may not cause actual body movement. This can take the form of a convulsion, characterized by generalized uncoordinated muscle activity, and or can be associated with a temporary alteration in consciousness. That's kind of how we normally, when you think of a seizure, most people think about the floppy fish, hitting the ground and all that kind of stuff. It's not necessarily, there's more to it than that. In the United States, it's estimated that 2 to 3 million people have epilepsy. It's a common cause of seizures. That's an actual disorder. So, and it's it's pretty common. I mean, 2 to 3 million people is a lot. Seizures are classified into two basic groups. You have generalized and partial, which is a focal. Generalized seizures, we're going to talk about first. This type of seizure results from abnormal electrical discharges from large areas of the brain, usually involving both hemispheres. So again, the brain just kind of flips out. And these being generalized, think of it like general anesthesia. It means it's pretty much everything, right? They're not just numbing up your finger, they're knocking you out. A generalized seizure is kind of the same thing. It's a total body experience. You're riding the lightning of whatever's going on, and it's not just one side of your body. This is typically characterized by unconsciousness and a generalized severe twitching of all muscles that lasts several minutes or longer. In other cases, a seizure may simply be characterized by a brief lapse of consciousness in which the patient seems to stare and not respond to anyone. So it basically, if the lights are on but nobody's home, is how I always put it. That could be a seizure. It's not always that somebody's just staring off into space or whatever. It's one thing if you're like, I'm just off in my own little world thinking. It's another thing if you walk up to somebody and you're snapping your fingers in their face trying to get their attention and they will not respond to you. That's what we're talking about there. So it doesn't always have the characteristic floppy fish. Sometimes it is just they just check out. The brain just shuts down for a second. They're awake. Their eyes are open. Their muscle coordination is all there. It's just their actual ability to interact has been seized up for a little bit. All right. Before we go into partial seizures, I want to make sure we get the names right. So if it's a short seizure, then it's called a petite mal. So think petite like small, right? Grand mal would be the big, longer one. And then if they don't come out of it, I think they come out of it, then they fall right back into it within a certain amount of time. Those are called status epilepticus, which is where you're just stuck in it. Normally, when you go to a seizure, it's over by the time you arrive. Like the actual flopping is over. But not always. Sometimes they are stuck in it, and it takes a paramedic to give them some medication to get them out of it and keep them out of it. All right, partial seizures. This begins in one part of the brain and is classified as simple or complex. If it's simple, then no change in the patient's level of consciousness. It could just be a twitch. I remember when I was in paramedic school, they showed us a picture of a baby, little baby, still in diapers, barely big enough to hold his own head up, and he was twitching. Like all of his arms would just, both of his arms, both of his legs would just kind of like twitch, like full body twitch, and the baby was awake. And it was actually kind of hard to watch it because the baby was starting to realize that something was wrong. Like, he was not the one making his hands and feet jerk like that. And so it was like baby sitting there and then twitch, and baby doesn't think anything of it at first. Then it twitches again, and the baby's like looking around like what's going on, and it twitches again, and the baby starts to kind of frown and like freak out a little bit, and then twitches again, and now the baby's crying, and then twitches again, and um, it was weird. It was hard to watch, and sometimes that's the case. You don't always lose consciousness. You might be well aware of everything going on. Um, Patients may have numbness, weakness, dizziness, visual changes, or unusual smells and tastes. Remember, I said your senses. I actually didn't say this, but your senses are controlled on the sides of your brain. So I'm sorry, some of them. Your taste and smell is controlled on the temporal side. So if that's where your problem is at, sometimes it'll activate the nerves that would normally be smelling something. You might smell something or perceive a smell that is not really there. It's just your brain kind of playing tricks on you. It may also cause some twitching or brief paralysis. All right. Complex partial seizures. The patient has an altered mental status and does not interact normally with his or her environment. So now these are where it starts to kind of attack your brainstem a little bit, your reticular activating system, your consciousness will start to go out in these. Results from abnormal discharges from the temporal lobe of the brain. Other characteristics may be lip smacking, eye blinking, and isolated jerking. Patients also may experience unpleasant smells and visual hallucinations, exhibit uncontrollable fear, or perform repetitive physical behavior. I know there are some drugs that do that too, but that's because they're affecting the same parts of the brain. Patients may experience an aura prior to their seizure. So this is basically they kind of get this feeling that comes over them that is a little forewarning that there's a seizure on the way. They can perceive this, they can feel it. So this can include visual changes, flashy lights, or blind spots in the field of vision, hallucinations, seeing, hearing, or smelling things that aren't actually there. People with a history of seizures recognize their auras and usually take steps to minimize injury, like sitting or laying down, because they know it's coming. And auras do not occur prior to every seizure. Sometimes they won't be there, and not all patients with a seizure disorder experience an aura. So, since it was mentioned in the class, I don't want to actually talk about anybody's medical history or anything, but who was it? If you don't mind talking about it, when you have your seizures, ma'am, do you ever experience the aura? Like, is this something that you can talk about? Either one of y'all.
I definitely experience auras. Um, it's actually a blessing in disguise because seizures are very scary, but I can always tell when, one is coming on. I start feeling weird. It's like the worst feeling because it's about to happen, but I have time to, like you said, lay down and prepare myself for it.
Yeah. How much of a heads up does it usually give you? Like, is it seconds? I don't think you have a lot of time. It's pretty much like,
I have minutes, and sometimes like I've learned ways of just of dealing with it because I wasn't born with epilepsy. I was diagnosed with it in 2011, like after the military, the army, and all of that, and like dealing with it. Like I found ways. I know it might sound crazy, but I start pacing back and forth and take an extra dose of my medicine and try to like fight it off, because it's like it's hard and it's a scary thing. So I just found different ways of coping with it and knowing what to do and different ways to deal with it.
I got you. Okay. And Tamara put into the text also, she said that a few days after one of her episodes, she had the same feeling, but it didn't go into another one. Has that ever happened to you as well, where you might get that aura, but it doesn't always lead to a seizure?
So sometimes like days after, like I won't have any taste if I've bitten, not necessarily my lip, but the side of my mouth. Like I'm extremely tired. I wake up and I'm like I'm just exhausted. I don't have an appetite. I just want to sleep. I'm very emotional. I'm not an emotional female at all, but after I have a seizure, when I wake up, I'm very, very emotional. Like, why is this happening to me? I get really, really scared. And then a few days later, I start feeling like my normal self. But afterwards, you definitely still, you don't wake up and feel 100%. And it's not a 30-minute thing. It takes days, a week sometimes just to, you know, get your strength back and build yourself up to get up.
I got you. Yeah, yeah, and I figure like especially if you have the tonic-clonic seizures where you do have the muscle spasms, um, we consciously control how much effort we put into a muscle contraction and how much force we want to do something. But when you have a seizure, a lot of times it's just full blown 100%. That jerk is everything that muscle can do. There's actually people who have ripped their muscles, ripped the tendons during a seizure because their arm, for example, yanked so hard that it actually ripped the muscle off the bone. Um, and so, yeah, sometimes it can take a long time to get your strength back from that. All right, so on to generalized seizures. Thank you all for talking about that, by the way. I, I have never experienced a seizure, thankfully. I've only had to do, like I said, usually they're done by the time EMS arrives. So all the seizure calls I've been on, they're usually post-ictal by the time we arrive. So we just get them and go. Anyway, generalized seizures. These are characterized by sudden loss of consciousness followed by a chaotic muscle movement and tone and apnea. So they can stop breathing on you because that's if you think about it, your breathing is automatic, right? We don't have to consciously tell ourselves to breathe, but when our brain is busy fighting itself, a lot of times those automatic features kind of shut off for a little bit. During generalized seizure, a patient may exhibit bilateral muscle movement characterized by a cycle of muscle rigidity and relaxation, usually lasting 1 to 3 minutes. Um, the patient can exhibit tachycardia, hyperventilation, sweating, and intense salivation. Most of your seizures last 3 to 5 minutes. And a postictal state, which is the time following the seizure, usually lasts about 5 to 30 minutes. And the patient is unresponsive. Sometimes they'll actually fall asleep, like just they'll be laying there snoring. Um, so next slide. All right. In contrast, an absence, or formerly called a petite mal seizure, may last for just seconds, after which the patient kind of wakes up and everything is fine. They may just not remember what happened. They'll be on the ground like what happened, ask you because they blacked out. That's what we want to happen, is that they come out of it real quick, because again, if your breathing shuts down, for example, because you're in a seizure, that's not good. We don't want you stuck in that. But sometimes they do. All right. This is called status epilepticus, as you can see at the top. This is a seizure lasting more than 5 minutes and likely to progress to status epilepticus if it happens. These things, it doesn't have to be one solid seizure. They can go postictal and then go back into seizing again, and then go postictal and go back into seizing again. It's still considered status epilepticus. That's where they're just stuck in it. Causes of seizures. Some seizure disorders like epilepsy are congenital, so you can be born with it. Others may be caused by high fever, which is a febrile. We talked about that. Structural problems in the brain, metabolic or chemical problems in the body. Um, so an example of that would be if your acid base level, your pH scale, if it gets too far into acidosis or something like that, it can cause a seizure. Your glucose getting too far out of whack can cause a seizure. Idiopathic, which means that they just don't know. Sometimes people have a seizure and we don't really know why. Epileptic seizures usually can be controlled with medications. So you ladies that have that, y'all are probably on some medication to help keep everything from getting too out of whack. Medications used most often to treat seizures include Keppra, Dilantin, phenobarbital, or just phenobarb, is what I've always grown up hearing it called. Tegretol, Depakote, Topamax, and Klonopin. Klonopin and Topamax are the ones that I have seen the most in the field. Even though there's others like Dilantin, I know I've seen before. Phenobarb, I've seen before. Phenobarb has other uses as well, but it's really good for that, for epilepsy. Seizures may be caused also by an abnormal area in the brain, so a structural issue could be a tumor. An infection, meningitis can cause it, and scar tissue from some other type of injury. So again, if they have had a previous stroke, sometimes they may, or if they had some head trauma, the scar tissue that comes from that could lead them to have seizures down the road. Seizures from a metabolic disorder can result from abnormal levels of certain blood chemicals, hypoglycemia, poisons, drug overdoses, sudden withdrawal from routine heavy alcohol or sedative drug use. Prescribed medications can do this. In fact, usually prescribed medications, they'll tell you like, don't operate heavy machinery because it could cause some issues. Seizures can also result from sudden high fevers, particularly in children. If a child has a febrile seizure, go ahead and take him to the doctor. It may be that they're just teething, or could just be the cold or whatever. But again, we don't diagnose in the field, and that is something that they need to be seen, because it may not be febrile. It could just be a coincidence that they have a fever at the same time. All right, so you must recognize when a seizure is occurring and whether this episode differs from previous ones. If you show up to somebody's house and they're having a seizure or had a seizure, one of the things you can ask the family is, was this one normal or different from any they've had before, and if they've had any before. Your patient may turn cyanotic from a lack of oxygen. Seizures may prevent the patient from breathing normally, if they usually do, depending on the kind of seizure that you've got. In a patient with diabetes, the blood glucose level may decrease, which could drive them further into hypoglycemia. So if they're to the point of having a seizure because of their diabetes, it could make a bad situation worse. If your protocol allows it, you can closely monitor blood glucose levels after a patient with diabetes has a seizure. And if they're awake, you can give them oral glucose or whatever it is at your disposal that can bring their sugar back up. You must look at other problems associated with a seizure. So patients who have fallen during a seizure may have a head injury. Patients with a generalized seizure may also experience incontinence. That's not a all the time thing. If somebody doesn't, poop the pants, that doesn't mean they were faking. I've worked with paramedics who took that as law, where it was like, oh, he's faking it because look, he didn't pee his pants or something like that. Just because you had a seizure doesn't mean you're going to do that. So just because you didn't do it doesn't mean that you didn't have a seizure. So don't let that one, you'll see that when y'all go out there, you're going to see people that have done that, or that's how they act. They're going to look and they say, oh, he didn't pee his pants, so he must be faking. It's not always the case. All right, your postictal state, this is the time after a seizure. Once the seizure is stopped, the patient's muscles relax, becoming almost flaccid or floppy, and the breathing becomes labored. The breathing pattern helps the body balance the acidity in the bloodstream. So if all of your muscles have started to contract, especially if you stop breathing during the seizure or whatever, you're going to be very acidotic, because all your muscle cells kicked into overdrive, used all that ATP, started creating energy, and then carbon dioxide is one of the byproducts of that. So you basically just had an influx of carbon dioxide created inside your body, and you haven't been breathing to breathe it out. So when you come out of it, a lot of times the body will hyperventilate to try to bring that pH back to where it needs to be. With normal circulation and liver function, the patient will begin to breathe more normally within a couple of minutes, unless there's, like it says, if there's something wrong, then it can take longer. But as long as everything is operating like normal, they're going to go back to normal vital signs pretty quick. In some situations, the postictal state may be characterized by hemiparesis or weakness on one side of the body. So it can kind of look like a stroke for a little bit when they're coming out of a seizure. It just depends on what part of the brain was affected. The postictal state is most commonly characterized by lethargy and confusion. And again, so like I said, they may fall asleep on you. That's happened where we get to the house and they're like, Uncle Ted had a seizure and he's asleep on the living room floor now because that's the postictal state. It just knocked him out. But be careful when patients have seizures and they go into that altered level of consciousness for whatever reason. They could be combative. It may be somebody you know really well that they've never heard a fly. That kind of thing. They're one of the nicest people I know, but they don't know you at that point. They don't know themselves. It could be their fight or flight kicks in or whatever, and there it goes. So keep that in mind. Don't just assume that somebody's not going to become combative when they're not in their right mind. If the patient's condition doesn't improve, you should consider other possible underlying conditions. So hypoglycemia, which we can't really do anything about if they're unconscious. You're going to need a paramedic to push them something IV. Infection can cause it. So again, it could be something like meningitis that could be causing that issue. All right, syncope. Seizures are often mistaken for syncope, which is feigning. If a person just kind of passes out for a minute, that's not a seizure. That's a syncopal episode, and that can be a couple things. That can be something cardiac related. It could be neurologic, like a stroke. It could be a blood pressure issue. Could be hypoglycemia. Syncopal episodes are not something that we can diagnose in the field. We just treat it for what it is, and we try to keep their primary life functions in check, their ABCs. Fainting typically occurs while the patient is standing, so you're going to have to probably take C-spine precautions if you think they might have hit their head on something on the way down. And then seizures may occur in any position. Fainting is not associated with the postictal state. They shouldn't. Their postictal state should not involve fainting. If they faint when they come out of it, they just wake up. So if you have somebody that goes down and then is, they've it's kind of hard to explain in the right words here, but a postictal state is associated with the seizure. So if they go into what you have learned about a postictal state, that should tell you that they had a seizure. If they don't, if they just wake up, that's a syncopal episode. When I pass out, it's because my heart rate is in the high 170s. Yeah, that'll do it. There's a point where your heart rate will get so high that your blood pressure actually tanks because your heart's beating so fast it's not properly filling with blood between beats. And then when your blood pressure drops, you drop with it. Altered mental status. Aside from strokes and seizures, the most common type of neurologic emergency that you're going to see in the field is an altered mental status. In fact, it'll come across dispatch like that. They'll say you're responding to 2701 Elm Street for elderly male patient, altered mental status. And that's all you get. The patient is not thinking clearly or is incapable of being aroused. It depends on how far into their altered mental status they go. Because remember, we talk about AVPU, right? If they're alert, then great. But if they're altered, that could be their orientation is altered. It could be that they are actually starting to pass out on you, and it will resemble them getting tired and going to sleep, depending on where they're at on that scale of things. Some causes include hypoglycemia, which is low blood sugar, hypoxemia, which is low oxygen in the blood, intoxication, delirium, drug overdose, unrecognized head injury, which in other words, they got hit, but you don't see any outward signs, brain infection, body temperature abnormality, brain tumors, and overdoses and poisoning. Some causes. All right, so we're going to talk about a little bit here. Hypoglycemia. We're going to have a chapter dedicated to diabetes, but patients can have signs and symptoms that mimic strokes and seizures because they're going to lose consciousness when their blood sugar drops too low. And they're also going to have some outward signs. They're going to kind of resemble, like their skin's going to be cool and clammy. Then you'll see some things that don't look normal. In these cases, the patients may have hemiparesis, similar to what occurs as a result of a stroke. The principal difference is that a patient who has had a stroke may be alert and attempting to communicate normally. The only question then becomes is, are they able to effectively communicate based on where the problem is at? Whereas if a patient is having hypoglycemia, that's usually almost always an altered level of consciousness. Patients with hypoglycemia commonly, but not always, take medications that lower their blood glucose level. So it could be that they took too much. For example, if it's a type 1 diabetic, maybe they took too much of their insulin and it dropped their blood sugar. Let's see. Okay, you said Elm Street because it's Halloween time. You got it. Patients with hypoglycemia can also experience seizures when it gets low, like really low. The brain starts to really kick up an argument, and a seizure is one of those ways that it does it. So your mental status with hypoglycemia is not likely to improve until you fix the hypoglycemia. They do tend to come out of it fairly quick whenever you give them some sugar. So a lot of times we don't even bring them to the hospital. So we fix their sugar, figure out why they bottomed in the first place, and then get them some food, and we go about our business. If they're type 1 diabetic, we may have to take them to the hospital if we find out through our assessment that they did do something wrong with their insulin, so they took too much of it. And we're fighting to get their sugar up, but the insulin in their system just keeps dragging it down. We may have to take them to the hospital, but usually hypoglycemia patients just wind up being refusals because we fix them on the spot. All right, delirium. This is a symptom, not a disease. All right, so patients with delirium, that's not a diagnosis, I guess is what you can say. This presents as a new complaint rather than a long-standing alteration in behavior. So temporary state that often has a physical or mental cause. It can be caused by an infection. It can be caused by changes in medication, especially if it's hormonal medications that can cause this. Hypoxia can cause this, and this may be reversed with treatment. Makes it pretty easy. Some signs and symptoms include confusion, disorientation. This is pretty much just that's what it is. Disorganized thoughts, inattention, memory loss, and striking changes in personality and affect. They can also have some hallucinations, delusions, and decreased level of consciousness if it gets bad, or whatever's causing it gets bad. The patient may experience rapid alteration between mental states, such as lethargy and agitation. They could basically be almost split personality in a sense, or manic, where they go from laughing to crying to different things, and they can happen pretty quick. Symptoms of delirium may mimic intoxication, drug abuse, or severe psychological disorders such as schizophrenia. So if they're getting hemmed up by the police, they may mistake them for being drunk, and it could be something else. Again, cops have gotten a lot better about that. Like if they don't know if it's an altered level of consciousness, cops are really good about calling out the ambulance just to check them out first. Whereas they used to not do that. There are a lot of people that would die in the back of cop cars, but that's not really the case anymore. They've gotten a lot better. Other causes of altered mental status. So basically, an unrecognized head injury. In most cases, a patient who appears intoxicated is just that. However, you got to consider that there could be other things going on. A lot of times, it could be their blood sugars dropped, or various things. Psychological disorders and medications can complicate things, and they could actually be the cause as well. Infections may cause altered mental status, particularly those involving the brain or the bloodstream. So again, we'll keep harping on meningitis, because that's a bad juju. That will kill you, and it causes a lot of issues. Have you seen altered mental status from LSD or mushrooms? As an EMT, no. As a college student, quite a few people I know, yes. But no, I've never had to respond to anybody for that. A lot of times they miss their medication too, and the more well-meaning, yeah. So it's not always that they did something on purpose, like they tried to get, they tried to overdose on something. A lot of times it could be that they either didn't take a med like they were supposed to, or they took it, forgot, took it again. I think assessment would be hard. Yeah, because their interpretation of reality is very, very off. So it's you almost have to treat them like they're not unconscious, like you're not going to talk to them or anything, but you can't trust what they're saying. Um, no, they don't. A lot of times they don't want to leave their house because they are going to freak out and worry that they're going to get in trouble. Um, and when I say freak out, I mean like they may go curl up in the fetal position in the corner and scream or something like that. Let's see, they can have AMS due to a UTI. Yeah, the UTI is an infection that can cause it. Um, you do see that, especially in, I will say, more poverty-stricken places, just simply because a lot of people don't want to go to the doctor, be it for health insurance reasons or whatever. Um, yeah, same thing. Geriatrics, we'll talk about that when we get to the last chapter of the class, which is geriatrics. But when there's some reason, some fear that they're going to get in trouble, or they're going to lose their independence, that kind of thing, they tend not to go get seen. And so you're going to see problems that would have never been an issue, but they are one because they didn't go to the doctor like they were supposed to. All right, we're going to move into patient assessment. I was going to take a break, but we're not. We're only 42 minutes into the hour. So basically, we're going to just like all your other chapters, right? You start every assessment with scene safety, BSI scene safety. Make sure that you're safe. Make sure you're wearing your proper um, gloves, all that stuff. Patients with an altered mental status may exhibit a wide range of signs and symptoms and behaviors, so you're going to have to really pay attention to your safety. Again, the 60-year-old grandmother or whatever can get pretty violent if she's having an altered level of consciousness. So just be aware of that. Look for threats to your safety, follow standard precautions, call for additional resources early, and consider what those resources might be. So if you need law enforcement on the scene, get them. If you need a paramedic, get them. Determine your mechanism of injury or your nature of illness, depending if it's trauma or medical. Look for clues to help you determine the nature of the illness, and there are special considerations for a patient with a suspected neurologic emergency. So in evaluating the environment, assess for any signs of potential trauma. Did they hit something on the way down, especially if it was a seizure? Any indications of previous medical condition? So get a good glimpse at their medications. Look for any signs of procedures, like a scar or anything of that sort. Look for evidence of a seizure. Ask the family when was the patient last normal? That's a pretty good question to ask people because, like I said, the person that's having the issue may not know that they're having the issue, and the family may be thinking about just that one symptom, whether the one sign, whatever they call 911. So that might have only started an hour ago. But when you ask them when they were last normal, then they're going to stop and think, well, now that you think about it, or now that I think about it, they haven't been normal for 3 weeks, that kind of thing. So that's a good question to ask. All right, for your primary assessment, it's your ABCs. So, sorry. Remember, your first priority is always to look for and treat life-threatening conditions. So we're going to do a rapid scan, your airway, breathing, and circulation. You can kind of start this as you're walking up to the patient. Get your information, look at the patient, try to figure out their LOC. And if they're conscious and talking to you, then fantastic. If they're unconscious, then we got some other things to kind of not take advantage of, but just pay attention to. Your initial impression will help you determine the severity of the situation. Use AVPU at this point, right? We're not, again, yes, I do want y'all to know the GCS, Glasgow Coma Scale, but in your primary, I don't want you sitting there wasting time trying to figure out what their 15-point range is. Just alert, verbal, painful, or unresponsive is good enough at this point. For your airway and breathing, stroke patients may have difficulty swallowing and are at risk of choking on their own saliva. So you may have to suction their airway if it gets clogged up, or if you start hearing fluid. Evaluate the airway of an unresponsive patient to make sure that it will remain patent. You may be able to put an OPA into somebody's mouth if you need to, depending on if their reflexes are in check. If it is, then go with an NPA. Be prepared to suction, position the patient, prevent aspiration. How do we do that? What's a good way to do that? What's the position called? The position the patient to prevent aspiration. All right, the recovery position. That's yep. There you go. Recumbent, left lateral recumbent. Normally the left. If you have to, you can put them on the right. It just depends. All right. Check for foreign body obstruction. Did they have a seizure or something right when they were eating a piece of steak and then swallow it whole? Assess the patient's breathing. All right. So again, if I told you that your 22-year-old patient is breathing 16 times a minute, and not going into any of the other contexts, just looking at the number, is that good? That's fine. Okay, good. Yep. Because what's the range? 12 to 20. Awesome. All right. Now, if I told you that their breathing was 10 times a minute, would that raise a red flag to you? Not really. No, there's a fudge factor to it. It's usually plus or minus 4. So anything above 8, anything below 24 is okay. And even in the testing, if they want you to know that somebody is breathing too slow or breathing too fast, they will give you a number that is well out of the range. So if I told you your patient was breathing 33 times a minute, that would be okay. He's breathing fast, right? If it's close to the range, then it's good enough for government work as far as the test is concerned. All patients with an altered mental status, regardless of the reason, should receive high flow oxygen. All right. So this is one of those, we talk about 94 to 99% trying to keep their O2 sat in that range. Not for altered level of consciousness. When that's what they're dealing with, or that's what you're dealing with, they get high flow O2, 15 liters non-rebreather. Just go ahead and do it, because whatever is causing that problem with the brain, we want to make sure that there's plenty of oxygen there. Yes, the free radical issue is a thing, but I don't want you guys to to let a patient stay hypoxic because we're worried about some cell damage down the road. You're going to be rushing these guys to the hospital anyway, so hopefully they're not staying on your oxygen tank too long. It is important to ventilate the patient at the appropriate rate with the proper volume. So again, we breathe 12 to 20 times a minute. I want you guys to give, like, if you're going to bag a patient and that's all you're doing is rescue breathing, one breath every 5 to 6 seconds is good, because that's 10 to 12 breaths a minute, and that keeps you at the bottom of that range, which is perfectly fine. Don't hyperventilate the patient unless the paramedic tells you to. We'll go over that when we go to the boot camp. There are going to be times where it would benefit the patient if you did hyperventilate them, but you need a monitor for that, because what you're trying to do is bring one of their vitals down to a certain range, and you have to be able to see that vital to know that you're doing it right. If you overdo it, you cause too much, you cause more harm. So that's kind of the problem there. So unless you got a paramedic there with a monitor that's looking at their end tidal, don't hyperventilate them. So if you do, you can see at the bottom half of your slide here what problems you're going to run into. There are some negative consequences. So you can overinflate the lungs, which can impair blood return to the right atrium and cause a decrease in cardiac output, right? When we bag a patient, we're using positive pressure as opposed to the negative pressure that we breathe with naturally. So if you're hyperventilating them, and especially if you don't give them enough time to breathe out before you shove another bag of air into them, you basically constrict the amount of space that the heart has to work with. And even if you don't hyperventilate somebody, if you're going to be bagging them for a long time, you're going to run into this problem anyway. It's unavoidable because we're not designed to breathe through positive pressure for long periods of time. Um, if you're doing that, they need to get onto a vent, one that can maintain a certain amount of pressure in the lungs. This also increases the risk of regurgitation and aspiration. So may cause severe injury in patients with intercerebral bleeding and increased intracranial pressure. That's one of the reasons why we want to do it, in a sense. If we have a stroke patient and it's a hemorrhagic stroke, when you drop your CO2 down to a certain amount, when you bring your pH to a lower amount, that constricts your blood vessels, which is normally a bad thing, right? We don't want to constrict blood vessels and starve the brain of oxygen. However, we're kind of riding a line there as paramedics. If we have a hemorrhagic stroke, we don't want to have all that blood just pouring out in the brain and causing other issues. So that's where we would controlled hyperventilate the patient. But again, we need to see that number. So this is not something that you would do on your own in the field. That's something that you coordinate that with a paramedic. All right, circulation. Begin by checking your pulses. If the patient's unresponsive, you want to make sure that you don't need to do CPR. If they are found to have no pulse, then that's exactly what you're going to do. If the patient is responsive, determine if the pulse is fast or slow. So again, what's our pulse range as adults? $60 to 100. Good job. All right. So again, if I told you that a patient had 110 for a pulse, yeah, that's fast, but that's not a problem, right? If I told you somebody had 210 for a pulse, that's an issue. And same thing on the other side. If they've got a pulse in the 40s, that's a problem. So, but while I say that, that's a problem. That's going to be a problem in the textbook. In the real world, some of your patients just hang out in that range and they're perfectly fine. Make your transport decision. If they are altered level of consciousness, they're going to be a high priority for transport. I'm going to just go ahead and I'll tell you that one now. I don't want you considering somebody to be stable if they have an altered level of consciousness. So because it's just not a thing. So, okay, yeah, and SVT is a little bit out of the scope for EMTs, but if it's atrial in nature, it would be SVT, but it could be ventricular. You could just be in VTAC, right? And that so it could just be tachycardia, like Donna was saying. All right, history taking. Almost to the next break. Investigate the chief complaint just like any other medical call. So don't get off in the weeds trying to do a head to toe assessment, for example, when it's not necessary. So when you do your history, you get your sample history. If they're alert and you want to know what something feels like, you can ask them the OPQRST questions. But even if not, let's say they're completely unresponsive, or you're having to ask the family questions because your patient is not able to communicate with you. There's one question in the OPQRST that I want you to pull out and ask every single time. Even if, like I said, that's a question that you normally, I'm sorry, that's a list of questions you normally ask your patient. But if it's a stroke or a seizure, mainly a stroke, you want to know when were they last normal. So how long has the symptoms been going on, right? That's the T in OPQRST. You can ask anybody in the room that might know that. That one question does not have to come from your patient in this case. Yeah, I mean, you're not wrong with SVT. I'm definitely not saying that you're wrong on that. It's just it could be more than that too. All right. I'll say this too. So when you're doing your history taking from your patient, um, try to talk to them first, right? Don't just immediately go straight to asking the family questions. Always start with the patient, give them that option, or give them that chance to try to explain it themselves. Um, but if you can't get that communication, um, then yeah, you may have to ask somebody in the family. All right, so there you go. Get your sample history. Um, what does sample stand for? We'll do it like this. What's S?
Symptoms,
Sounds and symptoms. Good. All right. What's
allergies,
allergies?
medication, pastoral intake, complications, events leading up to
Not provocations. That's the P in OPQRST. What's the P?
Past medical history.
Past medical history, right? Or pertinent medical history is probably the better way to say it because you only really want to know what applies to what you're dealing with. So pertinent medical history is pretty much what we're going for there. All right, your secondary assessment, which would include typically your history taking, but in this case, we're going to get our vital signs. Patients with significant intracranial bleeding may have a great deal of pressure in the skull that's compressing the brain. This slows the pulse and causes respirations to become erratic. They may be breathing very fast and very deep. Um, we call those chain stokes. So if you're seeing that kind of breathing, it basically the body is it thinks that it's got a lot of carbon dioxide or a lot of acidity, and so it's trying to off gas all of it. It's not able to really, like the receptors that maintain all that homeostasis and balance there, they're not working right. Um, so it'll cause the body to start hyperventilating, and that's not always the case. It just depends on when those receptors stop working, whatever message they start trying to send. If it says high CO2, then you're going to get that kind of breathing. If it says low CO2, you'll see your patient start breathing really slow and shallow. It just depends. Um, Blood pressure is usually high to compensate for poor perfusion in the brain. So if you take a blood pressure on somebody having a stroke, expect to see a systolic blood pressure that's up in the like 200s, and there's nothing you can do about it. It's a problem. It's a massive problem, but we can't fix that in the field. Even the paramedics are not going to be able to do anything about it. You have to get them to a hospital. Unequal pupil size and reactivity indicates significant bleeding and pressure on the brain. If the patient has an altered mental status, you should check the glucose level if you have the equipment available. Always, if your system will let you do this, always get a sugar check. Get a glucometer, check their blood sugar, because if that's the reason, you can fix that in the field, and you don't want to miss that opportunity, right? Because that can also be fatal if they're not able to if their blood sugar is out of whack. So if they have an altered level of consciousness, check that. It may not be a stroke. It may just be that they need some orange juice. Um, During most active seizures, it is impossible to evaluate vital signs, and this should not be your priority. So keep that in mind too. If they're actually still, flopping fish on the floor, you're not going to be able to get your blood pressure and vitals and all that, and really that's not your concern at that point. Um, so don't sweat that. You can get that later. If they're actually still seizing when you show up, your priority is going to be move stuff out of the way so they don't hit it, and try to maintain their airway as best you can. You can stick a pillow under their head so that if they, go to hit the floor, the pillow can cushion the blow. It also, if they're laying on their side, um, or if they're not laying on their side, get them on their side. That way, if they do start to vomit or get some fluid in their airway, it'll hopefully come out, and then suction them if you need to once their seizing is stopped. All right, it's now 8 o'clock for y'all. Take another break. See you at 10 after, and we'll continue on with the stroke assessment. All right, guys. I'm going to extend this break a little bit just because I'm trying to take care of something with a customer, and then we'll get right back at it. It's only going to take a second. We're almost done, actually. We just have a couple more topics to hit, about 20 more slides, and then we'll call it a night. Okay. All right. Sorry about that. All right. So your stroke scale, if you're going to deal with a patient that has potentially had a stroke, right? You don't know if it's a stroke or if it's a TIA, or it could be a couple of things. We want to try to figure that out. So the minute you start to think stroke, we're going to add this assessment in that you can do anywhere in your secondary. And that's where you plug this in. So you can do it around your vital signs. You can do it around your quick head to toe, that kind of thing. But this assessment is used to identify stroke in the field with a stroke scale. Stroke scale evaluates the face, the arms, and the speech. There's a couple of them that are out there. So the Cincinnati Pre-Hospital Stroke Scale and the Los Angeles Pre-Hospital Stroke Scale are the common ones. And I don't know about y'all, I've never actually used the LA. I always use Cincinnati. That's just that's what I used in my area. I don't know if you guys in different areas are using different ones or whatever, but to test the speech, ask the patient to repeat a simple phrase, something very easy, right? So you can say, I would like to have a glass of water. You know, have them try to say that to you. To test their facial movement, ask the patient to smile and show you their teeth. To test arm movement, you can have them hold up both hands in front of them, palms up, and see if one starts to kind of drift down. And you can also have them close their eyes, because when you close your eyes, or if you're looking at your arm, you're going to see when one starts to droop, and then you're going to try harder to keep that arm up, right? Because we don't want to not do what we're trying to do. So have them close their eyes. That way they don't see it. If they don't know, or if they don't visually see that one of their arms is drifting, then you'll actually get to see that unfiltered, like, okay, they really are drifting here. 3-item stroke severity scale, which is that LAG right there. So this looks specifically at 3 items: your level of consciousness, your arm drift, and the gaze. And then we have the fast mnemonic. This is something that you are welcome to use. I'm not gonna hold your feet to the fire for this. I don't remember if there's a test question on it or not, but it's not like sample, where you must know sample. You don't have to know fast, but I do want you to just know what it's doing, right? So facial droop, arm drift, speech, and the time, how long it's been since they were last normal. That's a pretty good thing that you can do for figuring out if somebody has a stroke, and then it's got the time in it so that you can get that to the hospital. All patients with an altered mental status should also have a Glasgow Coma Scale score calculated. So at some point, you will get your GCS. You can do that around your vital signs, perfectly fine. Because remember, like I said, your primary assessment is supposed to be fast. So you don't have to sit there and calculate a GCS at that point. You can just use AVPU. But you do want to get a point value for this. There's your Cincinnati Stroke Scale laid out for you. Facial droop, arm drift, and speech. Y'all do too? Okay, yeah, I haven't, like I said, Cincinnati is pretty much everybody's go-to. I don't know, maybe the West Coast uses the Los Angeles one, but everywhere I've been uses Cincinnati. All right, there's your Los Angeles pre-hospital stroke screen. So it factors in their age, history of seizures or epilepsy, a couple other things. That's not, like I said, it's it's new to me. I don't use it. You're not going to be quizzed on that, other than, what is it? You may get a question that says, what is the Los Angeles pre-hospital stroke screen used for? It's used to try to pinpoint a stroke. You don't have to know how it works, just know what it is. And there's your 3-item stroke severity scale. Same thing. You don't have to necessarily know this. You just want to know what it does. So fast. Yeah, okay, what is fast? Fast is facial droop, arm drift, speech, and then the time. So how long has it been since they were normal? If you notice, all of these basically do the same thing. So if you've learned one, you can kind of limp through all of them. They're all about the same. No problem. All right, and here's your GCS, your Glasgow Coma Scale. Something I want to point out about this: you get 3 for showing up. All right, the table I'm sitting at gets a 3. Nobody gets less than that, because there's no 0. It's eye-opening 1 through 4, best verbal response 1 through 5, and best motor response 1 through 6. So everybody gets at least a 1, or I'm sorry, they gets at least a 3. They get 1 for each of these items. And then if you look at it, the maximum points go 4, 5, 6, and they total up to 15. So us sitting here in class, we're at 15. If you start noticing, like, it hurts them to move, or if they withdraw from pain, that kind of thing, then you start knocking down their points. If they get to 13, they are a critical patient. Sometimes you may see a 14 or whatever, which isn't. It could just be a psychiatric issue. They're not really a critical patient. But if they're 13 or less, they're a critical patient. If they're 8 or less, um, a paramedic is going to be there trying to put a tube down their throat, and your patient's more than likely unconscious at that point. All right, for your reassessment, again, any altered level of consciousness is going to be a priority patient. So we're going to reassess every 5 minutes. And it's the exact same as it was in all the previous chapters as it will be for all the ones going forward. You're going to recheck your vitals, recheck anything you did in your primary assessment, and make sure that any interventions you had to do are still there and still working. Check for trends. So your cap refill, if you're going to do that. As always, don't get bent around the wheel about 2-second rule or anything like that, but just kind of keep an eye on it, see if it stays the same or if it gets better or worse. And then document. Oh, sorry, it's getting late here. Document and call ahead to the hospital. Let them know you're coming in with a stroke patient if you are indeed going in there with a stroke patient, because they need to get certain teams activated to meet you in the ER and start thrombolytic treatments immediately or whatever it is that they need to do. Because it takes sometimes, depending on the hospital, the neurologist is not always there. Like Forest General, for example, is level 2 trauma center. All your level 2s, they have all the different types of doctors, but they're not necessarily in the hospital, so they may be on call. So the sooner you can let them know, the better. All right, emergency medical care. This is going to be basically like, what are we going to do for the things that we find? Some conditions are easier to identify with treatment options that are readily available. The cause of other neurologic emergencies may not always be obvious to you. So, they may have to go get a CAT scan, for example. Some things we just can't figure out in the field. And because of that, we may not be able to give any real definitive treatment in the field. In most patients with a suspected stroke, physicians in the ER need to determine whether there is bleeding in the brain. We really don't know a lot of times if it's hemorrhagic or if it's a blood clot or something like that. But a big sign, like I was saying, if they are bleeding in the brain or bleeding in the head, look for that eye tracking, because you really don't see that with a blood clot. That's usually when pressure is being applied to the optic nerve. So that's a sign of a hemorrhagic stroke or just some kind of swelling in general, especially if it's trauma related. The only reliable way to tell is a CT scan of the head. And again, we don't carry those in the field. They're a little large. So we need to get them to the hospital. If there is no bleeding, the patient may be a candidate for blood clot dissolving medication. If there is bleeding, if it is hemorrhagic, this medication will increase bleeding with disastrous consequences. So if you're worried about, like, can you give your patient an aspirin or something like that? It gets a little tricky here, because if they are bleeding into the brain, that's going to make it worse. Some EMS systems designate specific hospitals, typically accredited stroke hospitals, for patients who may be having a stroke. I think the nearest one is in Louisiana, as far as you guys that are in like South Mississippi area. I think Slidell's got a stroke center. I can't remember. But what about you guys that are in Alabama and Arkansas and all these places that are further out from South Mississippi? Do y'all have a stroke center anywhere nearby? St. Patrick's in Lake Charles. Okay, so that's kind of out close toward Texas. What in fact, you're almost practically in Texas once you hit Lake Charles. None up there in Arkansas, North Mississippi area. All right, Grandview. UAB. Yeah, I figure UAB is a level 1, aren't they? So they got everything because they're a learning hospital. Montgomery's got one. Okay, sweet. So yeah, I mean they're popping up. I think even, and Wesley, correct me if I'm wrong, but was it you that was telling me that the Poplarville ER, can't believe Poplarville's got an ER, but they're a stroke center, or they're trying to be. Is that right? It was not me. Okay, I thought it was. I thought it was you. And I might have dreamed it for all I know. But anyway, only a limited number of treatments are available that are effective if started more than 3 hours after the stroke began. So again, that's kind of the issue about time being on your side, or time not being on your side. If you get there and you find out that the patient has been not normal since the previous night, that's a big deal, right? That's a problem because a lot of the treatments aren't going to work for them. Notify the hospital regarding the last time the patient was known to be without their current signs and symptoms of a stroke. Even if you are outside of that window, people keep don't let that be like, well, there's no need to rush now. No, it's still rush. It just means that some of their medications won't be effective, but that doesn't mean they can't do anything. Patients who have had a seizure require definitive evaluation and treatment in the hospital. So again, don't really sit on the scene for too long. Supplemental oxygen is strongly advised. So like I said, go straight to the 15 liters. This is one of those times where you're really not going to worry about what their O2 sat is. Just give them high flow oxygen. Most seizures will not require a significant amount of intervention on your part. Don't try to get, I'm going to say this, shouldn't have to say this, but don't try to put oxygen on your patient while they are seizing. All right, that's a great way for them to get tangled up and start choking themselves out. For patients who are having a seizure, if they're still having the seizure when you arrive, all you can do is protect them from harm. So move stuff out of the way. If they're around the table, move the table. Maintain a clear airway, suction if you have to. Provide oxygen as soon as they stop seizing so that you can, put that tubing around them and then not wrap it around their neck on accident. If you feel like they need oxygen because they're stuck in status epilepticus, you can give them, set your non-rebreather up and just kind of have it blow by into their face. It's the best thing you can do at that point. If head or neck trauma is suspected, provide spinal immobilization. For patients who continue to have a seizure, suction the airway, provide positive pressure ventilations if you need to. Get them in the hospital as quick as you can and rendezvous with ALS. So if you're on a basic truck, call the paramedics in. For a headache, like I said at the beginning of the class, most of your headaches are harmless. We really don't have to do too much for them. But if it is something that's severe, especially if it's being caused by a blood pressure issue, these are the kind of headaches that we need to be concerned of. So if they have a sudden headache with fever, seizures, altered mental status, or after a trauma, that's a big deal. For migraine, always assess the patient for other signs and symptoms that might indicate a more serious condition. A migraine by itself is not a problem, it just sucks. Apply high flow oxygen if tolerated. Sometimes they may not want a mask on their face because their head hurts too bad. And so you can provide a darkened and quiet environment. Don't use lights and sirens during transport for these patients. It just makes the matter worse, and it really isn't something that is necessary. So, like if you're going to transport a migraine to the hospital, which you probably will, I mean, you're talking about a kind of pain where they might need some medication that the docs are going to have to give them. Just do them a favor, do yourself a favor, because they're gonna let you know how much it sucks. Turn the lights off in the back of the ambulance. Turn the the sirens off, that kind of thing. All right, for stroke, support your ABCs. Again, as always, make sure that they're not going to fail on you. You want their airway, breathing, and circulation to be good. The patient may require manual airway positioning if they are unconscious or if they just don't have the muscle tone to be able to do it because that part of the brain got affected. Use a suction if needed, and monitor the patient's O2 sat with a pulse ox. Keep them at least 94, but I mean, like I was saying, when it comes to a stroke, just crank it up. That rule does still apply. Go ahead and give them high flow non-rebreather 15 liters. If they're rocking 100, then great, because they're rocking 100 at the finger. That doesn't necessarily mean they're rocking 100 at the brain where it matters. Routine use of oxygen therapy is not recommended unless the patient is experiencing respiratory distress or is showing signs of hypoxia. That's kind of a BS statement. I'm gonna retract that one, especially because we're talking about strokes. So if they're having a stroke, give them oxygen. The patient's paralyzed extremities will require protection from harm. So when you put them on the litter, for example, you may need to strap their arms inside of the seatbelt buckles that you have. You normally wouldn't do that, right? If it's an alert patient. But even in this case, like they may be awake and talking to you, but if they're having that weakness and everything, you just tell them, be like, hey, just because you can't really hold this arm up, we're going to go ahead and strap it inside of the straps. Talk to them, let them know you're not being restrained. If we need to loosen the straps, we can. This is just to keep your arm from falling off the side of the stretcher and getting caught on something. Do always talk to your patient and inform him or her of what's going on, because they're going to be a little afraid, especially if it's their first stroke. Even if it's not their first stroke, it's a scary thought because, like I said, people don't come back from these. If they can die, and there's not a lot we can do about it. So keep them informed, keep talking to them, even if they appear to be unconscious or they're not able to talk to you. Just keep talking to them. And if anything, saying what you're going to do out loud helps prevent mistakes, right? Because you might say it and then be like, wait a minute, that doesn't sound right. Or your partner may be like, why are you doing that? That kind of thing. Thrombolytic therapy and methods to mechanically remove the blood clot may reverse stroke symptoms and even stop the stroke if given within 3 hours for drugs or 6 hours for mechanical methods. So that's pretty good. I mean, that's 6 hours, unless they went down in the middle of the night, like right after they went to sleep or something. Usually a lot of times they'll get that treatment within a 6 hour window. Proceed under the assumption that an area of the brain can still be saved. Don't just write them off. The sooner the treatment is done, the better the patient's prognosis. And then, like it says, obviously, because time is not on your side, spend as little time at the scene as possible. Load them up, throw a family member in there. You can do everything short of your primary assessment and your scene size up can be done in the truck on the way to the hospital. Don't waste time at the scene. All right, for seizures, the patient may be in a postictal state upon your arrival. In fact, the patients will usually be in a postictal state on your arrival. Alternatively, the patient may still be having a seizure. Those are not the fun ones. When you walk in and they're still seizing, that's usually a bad day. Continue to assess and treat their ABCs. Try to give them oxygen if you can. Again, like I said, if they're still actively seizing, don't put a nasal cannula around their head or something like that, because they might, if they start rolling, they're probably going to wrap themselves up in it. They have no control over that. It's difficult to safely prepare a patient for transport who is having a seizure. So, if you get there and they're still seizing, if they're in status epilepticus, go ahead and call out a paramedic. Let the paramedic come out there and give them a medication that will stop the seizure. That way you can actually put them on the stretcher and get going. Assess for trauma. especially if you think they might have hit their head on something. Use your C-collar if you need to, and then never attempt to restrain a patient having a seizure. You're not just going to like strap them down. All right, don't try to do that. That's first of all, it's illegal. Secondly, it's not safe. It's not safe for you or the patient. Not every patient who has had a seizure wants to be transported, especially if they have a history of it. Right? And they wake up and yeah, they may wake up if they have a history of seizures and be like, no, I don't want to go. I'm fine. This happens. So if that's the case, just be prepared. You may have to discuss it with the hospital staff. You may have to discuss it with the med director or whatever if you think it's a bad, like a real life threat. Let's see, what do we have? I've been in legality for the miracle drug for those migraines. I can't remember what it is. We used to give a cocktail when I worked at the hospital at Keesler. Somebody would come in with a migraine. We would give them Benadryl, Sudafed, Tylenol, and I forget what the fourth one was, but it basically, yeah, I think it was Finnegan. All right. It basically just hit all the real known reasons for a migraine. It just hit them all. And so we'd give that to them, let them spend 30 minutes in one of the rooms with the lights off, and usually it worked. We never really, that way we didn't have to bother diagnosing and trying to figure out why they had the headache. We just fixed the headache and sent them on their way. All right, if the patient still refuses transport, ask yourself the following questions. Is the patient awake and completely oriented after having a seizure? So again, we almost gave that guy at the base, we almost let him do a refusal, but cover your bases. Even if they look completely fine, make sure that they're oriented. You never really know, or at least not at a glance. You don't always know. All right, and then for altered mental status, this is just like your catch-all, right? So signs and symptoms vary from simple confusion all the way down to a coma. If something happened to their reticular activating system, they will be out cold. It'll be straight up coma, and depending on what the damage was, they may or may not come out of it. It depends, but we can't figure that out in the field. So regardless of the signs and symptoms, if they are having an altered level of consciousness and altered mental status, that is an emergency that requires immediate attention. So they are a load and go. You pretty much, from the minute you walk onto the scene and see that they are altered, you know that you need to get them into the truck and get going. And if they are altered, they can't refuse because they're not in their right mind. So that's it. Let me catch up on some of these texts. Let's see. May have been. Yeah, and it depends too. Your different ERs are going to use different things. It's whatever the med directors want to go with. All right, give me a second. Is there any questions tonight while I'm pulling up your pen? Okay, what you got? While you're typing it, your pin for the night will be B as in Bravo, C as in Charlie, 17N as in neuro, BC17N. Okay, yeah, no, that's fine. Otherwise, that's it for the night, guys. If you have any questions, I know Tamara, you're typing, so that's fine. Everybody else, if y'all want to bounce out, you can. if you have any questions, by all means, stick around and ask. I'm gonna go ahead and stop the recording.